Hello and good afternoon to everybody. My name is Mike Hamilton. I'm Medical Director at ISMP Canada. Welcome to the winter edition of the Med Safety Exchange, and thank you for joining us today on Wednesday, January 28th. We're very pleased you've chosen to spend some time with us. And as we settle in today and maybe get a cup of hot cocoa on this cold day, I'll ask our Brock University student Larian to perform the land acknowledgement. Larian?
Thank you. We begin with a land acknowledgement for our office in Toronto, and I encourage you to reflect upon where you work and reside. We acknowledge we are hosted on the lands of the Mississauga of the Anishinaabe, the Haudenosaunee Confederacy, and the Wendat. We also recognize the enduring presence of all First Nations, Métis, and Inuit peoples. We are grateful to live, work, and play on this land, and we want to contribute to the implementation of the Truth and Reconciliation Commission's 8 health-related calls to action. This webinar is a production of ISMP Canada and the Canadian Medication Incident Reporting and Prevention System, CMIRPS, with contributions from all of our partners in medication safety and you, the audience. For confidentiality and participation purposes, we ask that no AI bots or automated assistants be present during this meeting. A recording of the webinar will be available in the near future on our website. The Med Safety Exchange is presented on the Zoom webinar platform. Audience members are automatically muted and your video is disabled. The presentation part of this webinar is being recorded and will be available on our website in about 2 weeks or so. There are a few ways to make comments or to submit questions. Find the Zoom toolbar typically at the bottom of your screen. The chat panel is also open for the broadcast, so feel free to introduce yourself and tell us where you're from. You can also make comments and ask questions via chat. All chat entries will be visible to the audience. If you select the Q&A tool, a window will open up. You have the option to submit anonymously if you wish by checking off the lower box. Responses will appear in the Q&A panel, and questions will only appear in the panel once they are answered. We'll try to get to as many questions as we can, and at the end there will be an evaluation poll at the end of the session, and we encourage you to provide feedback. Now back to Dr. Hamilton for an overview of today's session.
Thanks so much, Larian. Our broadcast today is varied and compelling, and it really demonstrates the wide range of topics, the wide range of perspectives, and it highlights the many approaches and tools we can use when practicing medication safety. Importantly, I think it establishes that all sectors, all disciplines, all roles play a part in delivering safer care. We'll start off with 2 presentations about a form of medication harm that remains under-recognized despite the availability of processes that could potentially mitigate harm. We'll learn about the harm, about some of the strategies and steps that can be taken in the community pharmacy. Another underappreciated form of harm comes from IV fluids. Now, last spring, we learned how fluid storage can contribute to harm, and certain tactics can reduce that risk. Today, we'll dive deeper into these vulnerabilities in fluid packaging and labeling. And the National System for Incident Reporting is really a critical component of Canada's healthcare safety infrastructure. And we'll finish the day with an announcement and some updates regarding this important work. Now, we're very fortunate that we'll start off today with a story. Medication harm happens to real people, to loved ones, and we should never lose sight of that. We are honored to have Dr. Kapoor, a clinician and a family member, to tell us of his family's experiences and some strategies on how to prevent future harm. So I'll hand over slides to you, and
perfect.
It's all yours.
Thank you very much. Thank you very much, Dr. Hamilton. The initial title for this talk was Strategies to Mitigate Toxicity from Fluoropyrimidines. However, I've been a bit more ambitious and elected to provide strategies that could potentially eliminate death from fluoropyrimidines. I wish to thank the staff at ISMP Canada for including me. These are my affiliations and credentials. I'm the brother of Dr. Anil Kapoor, no financial relationships. I would like to point out that ISMP has produced an excellent document on this subject, and I encourage you to go to their website to review their document that they have produced on this same subject. This is the outline of our talk today, and I'll begin the talk with some questions. What if I told you that I was giving you a drug that had a risk of death of 1 in 500? Would you be concerned with the risk of death of that drug? What if I did not tell you that there were 5 ways to significantly reduce your risk of death from 1 in 500 to 1 in 1,000 or less? Would it bother you? What if I told you that a test to mitigate this death was very cheap, between $50 to $300? Let me show you one of the 5 ways to reduce risk of death of this drug. What if I told you that you could have a genetic variant in your enzyme that's supposed to break down the drug that's really present in 2 to 8% of the population that would increase your risk of dying from this drug to as high as 1 in 30, depending upon the variant you have? What if I told you that doing a simple blood test would reduce your risk of death significantly? So just to illustrate this graphically, with no screening test in the general population, your risk of death is about 1 in 500 from this drug. Given the screening test, your risk would reduce to 1 in 1,000. However, if you are one of those people, the 2 to 8% of the population who has a genetic variant in this enzyme, your risk of death is 1 in 30. And you'll see that with the screening test, your risk goes down to 1 in 1,000. What if you or a loved one died from this drug and no one told you any of this information in these past slides? Well, this happens to about 1,300 people a year in the US, and by extrapolation, about 130 people in Canada. And here are some of the people who have passed away in this manner, one of which was my own brother, Dr. Anil Kapoor. My brother was a world-renowned urologist, renal transplant surgeon, uro-oncologist, full professor at McMaster University. My brother was a renowned expert. He was a gifted surgeon. He was an internationally sought-after speaker. He was a son. He was a brother. He was a father. He was a partner. He had many friends. And just to show his personality, he was a very humble individual. Here he is in his final tweet honoring the cleaner who worked at his hospital where he worked. Here is the final days of my brother. My brother had a colonoscopy on January 14th. He had a diagnosis of colon cancer, which very much surprised him. He had a CT scan on the 20th to show how functional he was. He went to a basketball game on the 21st. He had an oncology appointment on the 26th. This is the weekend before starting his chemotherapy infusion. Here he is at the hospital. Here are his final days. He began his chemotherapy on the 6th of February. Overdose signs and symptoms presented on the 10th within 96 hours. He proceeded to the emergency room on the 12th, again within 96 hours. He proceeded to the emergency room again on the 16th. This time he was admitted to the ICU shortly thereafter. He was intubated, and he passed away within 22 days of starting the chemotherapy. This is repeated over and over if you review charts of people who have passed away in this manner. All of us are physicians, and we did not know at all what happened to our brother and how he died. Again, this is repeated all over the world again and again. We got to know what happened until a phone call from the oncologist about 2 months later, which I'll address later. So the drug, as you've guessed, is 5-FU-fluorouracil in the IV form, and the pill form is capecitabine. Together, these two drugs are classified as fluoropyrimidines, and they're used, as you know, in head and neck cancers, breast cancer, and gastrointestinal cancers. We all have a DPYD gene that breaks down this drug, and if we have some variants in this, we will accumulate toxic metabolites that can be life-threatening and unable to excrete the drug, and it can kill us. How easy would it have been to save these lives? The next slides begin with just one of the five, and I'll address all of them. So before being given the drug, you would take a blood test. You would determine if you have a variant in your DPYD gene. You would then go to this table if you have a variant, and you would adjust the dose accordingly. Instead of being given a full dose of 5-FU or capecitabine, you would adjust it based on this table and reduce the dose. This is very simple and easy to do. In fact, in certain jurisdictions now, as of 2026, we are pre-testing. The leaders, however, in this are in Europe, and since 2020, they have been testing people before being given a fluoropyrimidine, with France legislating this. Australia just recently came online. In North America, we will see that previously Canada was somewhat ahead of the US, but it's flipped, and the US seems to be surging ahead now. I will explain this. Previously in 2023, the only state that legislated and still does legislate is Louisiana to do DPYD testing, predominantly from one or two people who have led this. However, as of 2026, there are some changes that have led to rapid adoption of DPYD testing throughout the United States. In Canada, this document provides an outline of who provides testing in Canada. I've just updated this. It looks like as of December, Alberta has come online. However, still Manitoba, the territories, and the Maritimes appear to be still, some of them are not covering or doing DPYD testing prior to giving fluoropyrimidines. So why was Europe ahead of Canada and the USA? I'll provide some history. So this is predominantly due to these guidelines, the NCCN guidelines. These guidelines that did not recommend pre-testing for DPYD up until April of 2025, excuse me. And these guidelines are important, even though they're American, because to a degree, the whole world does refer to them as for guidance. This has been substantiated by this paper published in Bulgaria, which shows how much they rely on these guidelines. There are since the 1980s, there have been about 1,500 papers in this particular subject. However, the guidelines cited only 1.3%. We have no idea how they selected these papers. The chair is selected by the senior staff. The chair selects its members. There's no term limit to the chair, and the committee members have no term limit, the people who generate these guidelines. With the exception of randomized controlled trials, level of evidence is based on a vote of the committee. The chair basically chooses his committee members, where they sit on for unlimited times, and they get to arbitrarily select what papers they want to cite as a basis, and the level of evidence is based on a vote count. I believe this picture speaks for itself. In fact, these guidelines were analyzed by this Canadian paper, where they analyzed global guidelines. They found that the NCCN guidelines have no analytical framework and have very low score in terms of rigor of development. Nonetheless, they had a hold on the whole United States. Until the FDA came and made some changes. And October 3rd, 2025, not too many months ago, they ordered that testing be done before being given fluoropyrimidines, mainly the oral form. The IV form, I'm sure, is coming. To their credit, the NCCN did follow suit on October 30th, including the oral and IV form, indicating that testing should be done before being given these fluoropyrimidines. In Canada, our statement in Health Canada is still very tepid, and it says testing should be considered. But doctor, my brother was tested, so why did he not survive? Well, because the test only included 5 alleles prevalent in Northern and Western European populations. This was his allele variant. This allele, however, was published in literature by the Dutch in 2008, who are leaders in this field. Again, it was published in 2020, and again in 2024. In fact, it is not only my brother who was skipped, but more than 60% of the Canadian population would be skipped if we just use the traditional allele testing. In Ontario, at least, they seem to acknowledge this, but there's really no action taken. And deaths continue to occur. This is Christopher, who also passed away at the same institution as my brother. And sadly, he was cured of his cancer given adjuvant capecitabine, and he died again within 17 days. There was an update in Ontario in September 5th. However, it wouldn't have still affected these lives. But the US are acting very quickly. This variant has been included in a number of testing centers throughout the United States. I want to go back to the phone call from the oncologist that was received 2 months after my brother died. He indicated that my brother's variant was very rare, 0.00001. That's 4 zeros and then a 1. However, the database on which this is built, in fact, has very few South Asians in it. Only 60,000 South Asians, but over 1 million people of European ethnicity. Of course, the denominator is very low. But there are at least 1.5 billion people of South Asian ethnicity. So only 0.004% of the South Asian population is included in the genome database. If you don't look for it, you won't find it. So what are the solutions? I'll get to these solutions. The solutions are, number one, is to consider sequencing the full DPYD genome. And this is being done at US and Canadian and some Canadian centers, including Europe. It's a phenotype test called Uracell, and these are both, combining them would be very cheap. Dr. Brooks in Dartmouth College, Hanover, New Hampshire, does sequence the full DPYD gene there for all his patients. Another key solution is therapeutic drug monitoring, which has been recommended to be done for 5-FU infusion. And this has now been approved by Health Canada as of 2024, and some Canadian centers are testing this. The other solution to prevent death is there is an antidote. The antidote is called VistaGuard and has been available since 2015. It is available by special access, but if you follow these very simple steps, you can get it within 24 hours. Is the patient very sick very early? Is it within 96 hours? If yes, make 3 phone calls. This lecture will be available after, and this is the key slide, which the 3 phone calls, you may have tested this after hours, and it does work. If every operating room can carry dantrolene, which is a antidote to malignant hyperthermia, which has a risk of 1 in 100,000, surely we can have the antidote for something that kills 1 in 500. Can one person lead change? Well, yes, they can. Any one of you can lead change at your center. This is Colette with her husband. With her permission, she wanted me to show these slides of what this drug does to people with DPYD deficiency. And this is what happened to my brother very quickly, what it does to you. Not just kills you, but leads to excessive suffering. Colette led change in Quebec and transformed Quebec to do DPYD testing. She was initiated the first province to do this. Here's another change agent, Lindsay. This is Lindsay's mother, Carol. She died at Dana-Farber. She was not tested. Lindsay led change in this whole institution. This is Karen and her husband, Larry. He also was not tested. Again, he was given capecitabine as adjuvant. She led change and transformed Mass General. However, this is Ken. Ken has formed this organization after the loss of his wife, Advocates for Universal DPYD Testing. But the current approach is not working. The current approach to fixing this problem, which involves killing people and then testing later, is not the way to solve this problem. Patients and clinicians need to know what is going on. They need to communicate the risk of these drugs. In summary, in conclusion, we should stop all fatalities from fluoropyrimidine exposure. And the key approaches are these 5 methods: gene sequencing, uracil phenotype testing, have the antidote, recognition and communication, and drug level monitoring. There's no excuse. We can easily prevent death from fluoropyrimidines. We should recognize the diversity of populations, and one person can lead change. I leave you with a quote from this poem from my brother that he liked very much. This talk is dedicated to my brother. Thank you very much to all those who assisted.
Thank you, Dr. Kapoor, for your family's story, for the willingness to tell it. I think the opportunity to learn from tragedy, certainly your passionate guidance and your frequent reminder, which we need, is that one person or small groups of people can make a difference. So I'm hopeful that everyone will take note of this and continue the work, expand the work. Thank you.
Thank you very much.
When I entered practice, there were very few oral chemotherapy medications. Most were delivered in IV clinics, and that's changed. More and more oncology medicines, including what you've heard, the fluoropyrimidines, are available in formats for home use to be dispensed by community pharmacists. And there's that layer of safety needed at community pharmacy level in the community for home and self-administration. And our next speakers have recognized that, and we are very pleased to have them tell of their work as an adjunct to what you've just heard. So, Erin, I've handed it over to you.
Perfect. Thank you. You're able to hear me okay?
Very good.
Okay. Thank you so much, Dr. Kapoor, for that very heartfelt story and for the excellent overview of testing. For that reason, I'm not going to spend a lot of time today talking about testing and, of course, the imperfections of testing, but more so a quick overview of tips for the pharmacist in the community if you happen to be dispensing capecitabine to patients in your practice. So capecitabine, as we mentioned, is an oral form or oral prodrug of 5-FU and is commonly prescribed as a take-home cancer drug and may be dispensed from a community pharmacy or be dispensed to patients for whom you provide care in another capacity. So pharmacists do have a role in supporting patient safety for people prescribed systemic fluoropyrimidines. And the number one thing you can do is to ask your patients if they're receiving anti-cancer treatment with these medications, is make sure that they're aware that they require in some provinces or should be asking about pre-treatment genetic testing to reduce the risk of harm and toxicity. So if the patients are unaware that these tests exist, or if they're unaware if they have been tested, they were not given any results, it would be a good idea to direct them to their oncology team before initiating treatment to make sure that they have all of this information or that they've received their results from their testing. Make them aware that some people, as we've just covered, some people are at an increased risk of severe side effects or harm due to genetic mutations that reduce their body's ability to break down this chemotherapy. And it is important that we understand, of course, that not all possible genetic mutations that can lead to the deficiency in this enzyme are necessarily identified on all available genetic tests. If we look by province, standardized testing varies widely across Canada. It is recommended and established in some provinces, but other provinces are still working towards implementation. So the funding, whether it be public or private, varies across the country. So if you're ever unsure, you can consult provincial health service websites for accurate, up-to-date provincial testing information. Some examples being organizations like Cancer Care Ontario or BC Cancer Agency. So I'm fortunate to practice in Ontario where this testing is established, and this medication, generally the prescription doesn't get sent out or is not dispensed until these results are back. But as of course we've just covered, this is not it's not a perfect system, but at least there is an established baseline for some testing. Some resources that you can keep in your community pharmacy that you could share with patients newly starting this medication if they're unsure, if they've perhaps not had these discussions about testing and why there is testing for patients taking these medications are available through Cancer Care Ontario. So this document is a nice little one-pager about what the medications are used for, what this enzyme is, what does it mean to have a deficiency in terms that the average person could understand, and to explain to them why this testing and awareness of this testing is important. There is also a nice one-pager from Colorectal Cancer Canada about how to discuss this with your doctor. And of particular importance, perhaps, if you live in a place where this testing is not established, or potentially a patient may have to access it privately if they would like to seek this information. As the pharmacist, really there's a big part in educating the patient. So as we know, the testing is certainly not perfect, and there are patients that will be missed because of this, or because they perhaps have less common variants or variants that are not included in standard testing. So it's important to make patients aware of common toxicities and how they can be managed when initiating treatment with these medications. So patients, number one, should be counseled. Of course, you hear these stories every so often of a patient who walks out of a pharmacy without being counseled at all. And so please make sure you take the time to speak to patients who are newly starting chemotherapy. And I know for community pharmacists, this isn't always an area of comfort. I'm lucky to work in a specialized oncology practice. We see only patients on oral treatment for cancer. So we talk about this all day. But I can appreciate that for some community pharmacists, this may not be something you see on a daily basis. It may not be something you have a lot of experience managing. But some of the main counseling points that you should be covering with patients newly started on capecitabine would be to discuss the risk of diarrhea, mucositis, which is inflammation or sores or tenderness in the lining of the mouth or even the esophagus, nausea, hand-foot syndrome, and of course the risk of myelosuppression, which comes with many forms of chemotherapy. It's important to encourage patients to report their symptoms early, especially if they're severe and if they're not responding to the usual supportive care. So when monitoring these patients, diarrhea is something that can occur early, so within the first days to weeks of treatment, and patients should be counseled on the appropriate use of loperamide and understand the importance of reporting severe symptoms early. In many cases, patients do rely on loperamide, sometimes on an as-needed basis when they're on this medication, but certainly if you have a patient that, say, 2 days after starting therapy is calling your pharmacy to say that they're having 6 episodes of loose, watery stool per day. They've noticed blood in their stool. These should be red flags that you are sending that patient to the emergency department for an urgent assessment. Patients should present to the nearest emergency department if they develop a fever. When they're on, it's a somewhat of a general recommendation when on chemotherapy, but in this case, of course, could be a sign of a more severe toxicity if they're experiencing significant early myelosuppression because of an enzyme deficiency. Hand-foot syndrome can occur early within the first days to weeks of treatment. For some patients, they feel this as a burning or a tingling sensation in their hands. They may notice some dry skin, a little bit of peeling, but more significant symptoms such as swelling, redness, if they've noticed bleeding, cracking, desquamation, blistering of the hands and feet, this requires an urgent assessment. And again, as we know, time is of the essence if this is related to deficiency, because that antidote needs to be given within a specific time frame. The potential for nausea with capecitabine is considered to be low, and it is not a chemotherapy that you will necessarily see routine prophylaxis be given. So you may see your patients have an as-needed prescription for an antiemetic, but not necessarily needing something as prophylaxis unless they've perhaps had issues in the past. So it would be something that would catch my attention if a patient called me to check in after starting treatment and reported severe nausea and vomiting after starting this treatment, especially if it was nausea and vomiting that was not responding to their antiemetic. This would be something I would refer for assessment. Mucositis or stomatitis can occur early within days to weeks in treatment, and patients should be aware that they should be reporting any severe pain, any visible mouth sores that are impacting their ability to eat or swallow. These are all symptoms that should be assessed. So when to refer, I think I've touched on it with the various side effects, but just to know to refer. If patients have severe symptoms, especially early on, have them, if they have a phone number for the cancer center, for a patient helpline, that if that's easily accessible, to give them guidance of going to emerge versus coming into a clinic, but certainly make sure that they are assessed urgently if they're showing any of these signs of severe side effects. And as we discussed earlier, that there is an antidote available, but it must be administered within a specific time frame. And it may not be something you look at on a regular basis in community pharmacy practice, but familiarize yourself with the common terminology criteria for adverse events. And this exists for all side effects or most side effects that can happen due to oral anti or any anti-cancer treatment. And there's a grading system in terms of severity. So I've just chosen the example for diarrhea just because it's relevant to capecitabine. But you'll notice, oh, my animation. There we go. Grade 3 and 4 would be considered severe, and patients that fall in this category, so an increase of greater than 7 stools per day over their baseline, you want to send these patients for an urgent assessment. I would even argue grade 2, if someone had an increase of 4 to 6 stools per day over their baseline, 24 hours, 48 hours after starting capecitabine, and especially if it's not responding to loperamide or no improvement with loperamide, these patients it would be reasonable to tell them to seek medical attention. Oh, sorry. And this is just to highlight for our group at Extend, we offer education materials for community-based pharmacists. So there's the QR code here if you'd like to join, but give an example in the bottom corner, we have monographs that we've made for various oral anti-cancer treatments that review possible side effects and the time frame and their management. We offer webinars and various infographics, so feel free to follow along if you would like to supplement your understanding of oral anti-cancer medications, if it's not something that you see regularly in your practice, and if we can help support you in any way. Thank you.
Thank you so much, Erin. Really welcome your advice for community practice, and really thankful for all the work you put into this. And I think the audience can really appreciate how this integrates and complements some of the strategies outlined by Dr. Kapoor, and really reinforces that we need sort of protections at every level. We need these layers to keep people safe. And certainly, community pharmacy is a really frequent and important point of contact for patients, so it's critical that everyone's aware of that. Thank you. And now we'll turn our attention to IV fluids. And, it's well known that IV fluids cause patient harm. And we at ISMP Canada, we almost weekly receive reports proving as much. And there are many reasons behind the errors that happen. But certainly similar packaging, complicated, confusing, over-inclusive labeling can combine with the way we store it, as we learned earlier last year, to put patients at risk. And we're very grateful for our next presenter for helping us raise awareness of the issues.
Thanks so much, Michael. I appreciate the opportunity. As laid out, I'm going to discuss a couple of different issues with respect to IV fluid labeling. And at the end, I'm going to kind of make a plea and see if anybody's interested in forming some sort of a panel with me. But first off, next slide. I would like to acknowledge that I'm in Mi'kma'ki, the ancestral territory of the Mi'kmaq people. The Nova Scotia, the province that I work in and serve, is a small part of Mi'kma'ki. I also acknowledge the history, contributions, and legacies of the African Nova Scotian people and communities who have been here for over 400 years. Next slide. So some of you may have heard this term, IV fluid stewardship. It seems to be getting a lot of press. My colleague Nancy Connor discussed some aspects of it not long ago. the previous ISMP webinar, it involves a number of different disciplines. It involves not only the people that are doing bedside care, the physicians and the nurses who are hanging the bags, but it also involves people who are distributing IV fluids to the floors, stocking the shelves, and basically IV fluid stewardship in a nutshell is right fluid, right rate, right person, right duration. Next slide. This not exactly the best example, maybe, because this is relatively well organized, but a lot of med rooms that I've walked into certainly have just a plethora of IV fluids, and it's just like it can be overwhelming. Like, why do we need all these different? How are these different and whatnot? Next slide. Thank you. So on the right here are some of the data that Nancy Connor had collected during one of her surveys, and you look at all these different fluids and like, how are these different? Why do we need all these? Well, for starters, I think we need to have some sort of a formal review at a higher level and establish a formulary, which ones do we need, which ones can we get rid of? And one of the questions I've been asked is, can you make us a chart maybe that kind of lists the different fluids and what their different properties are? Next slide. I can certainly make you a chart, but the chart is going to disagree with a whole lot of other sources. So, for example, this is an article that I've submitted to be published along with a couple of colleagues. We basically look to see, what sort of nursing cheat sheets are out there. So we went into Google Images, and so our search terms were nursing IV fluids. Next slide. And we took the top 5 hits, and there was just a plethora of errors. Some of them were just mostly some like minor errors, but some of them were just outright like, don't use D10 to use cerebral edema. That's just flat out contradictory to the process that you would use. There's just a whole plethora of information that it all seems to surround the difference between tonicity and osmolality. So the topic of tonicity relates mostly to the presence of free water. And I'll leave it at that. I'm not going to get into the specifics, but tonicity and osmolality are 2 different things. Next slide. Thank you. Now, this is an article that I published with a couple of nephrologist friends of mine a couple of years ago, where we reviewed the labeling of 28 different crystalloid solutions, and 27 of them were labeled incorrectly. Looking at the hypotonic fluids, that particularly we want to avoid hypotonic fluids in particular in certain patient populations. Of the 18 hypotonic fluids, 11 of them were actually incorrectly labeled as hypertonic on the bag. Next slide. Again, this is a topic that's fairly complex, and I'm not going to get into it, but there are certain people that are very sensitive to the presence of free water or hypotonic fluid. You can actually make patients iatrogenically hyponatremic if you overprescribe too much free water. And in patients that are young or have cerebral edema, you definitely want to avoid hypotonic fluids. Next slide. So again, so I could make you a chart that kind of lists the fluids in terms of hypotonic, isotonic, and hypertonic. But then, somebody goes into Google and types what fluids are hypertonic, and this is what you get, copied and pasted. Sure, 3% or 5% sodium chloride, those are hypertonic, but D10 is not hypertonic. It's hyperosmotic, but it's not hypertonic, and neither are the other 2. So like 25% of these are hypertonic, the rest are not. Next slide. So I really would like to create a central source of truth. I'll make the chart. I'd like to publish it on ISMP, forward it to the manufacturers, and start reaching out to other sources such as textbooks so that some of these errors can be corrected. Next slide. Thank you. So my recommendation 1, or recommendations 1A and 1B, if you will, liaise with IV fluid manufacturers to correct the tonicity information, both on in their monograph in the bags, and then create a chart, publish it to ISMP, and then I can reference that chart and say, well, it's not just me that's saying this is it. It's actually ISMP that says that this is factual information. Next slide. And to finalize, I'd like to ask the question, can we possibly improve the way IV fluids are labeled overall? Next slide. And ISMP has been aware of this issue. These are 3 different types of fluid. Next slide. And a bigger picture. And again, 3 different fluids. They look very, very identical. When you're looking at these displayed in a tray, I guarantee it's not easy to figure out which one is which, especially if you're in a hurry. Next slide. Now, I'm going to read from this, although it's a little long. This is from ISMP 2024. Given the reports of IV fluid-related errors and the potential ambiguity and confusion related to labeling of some IV fluid bags, we suggest the development of a good practices guide for the labeling and packaging of IV solutions, similar to the guides that exist for the labeling and packaging of prescription and non-prescription drugs. Why wouldn't we do this, right? Such a guide would include the following considerations. What is the critical information that needs to be on the bag? What is non-essential information? In other words, what's label clutter? And easily readable barcoding. Next slide. So what is label clutter? Well, the FDA in a couple of different documents, I think it was like 2013, and they recently updated it. They came up with a list of things that are considered to be extraneous. They don't need to be on the label. Next slide. So, for example, do we need to know the pH on the bag? No. Do we need to know that certain solutions aren't compatible with blood? No, not on the bag. Do we need to know, is this pyrogenic or non-pyrogenic? No. So I've taken 3 different randomly selected fluids from 3 different manufacturers, and the vast majority of them have clutter. Next slide. And there's more label clutter there, right? We don't need all this information present on each and every bag because it clutters, as the name would suggest, but it leaves less room for pertinent information. Next slide. Oh, okay. If anybody here hates all caps as much as I do, that would be something. I find all caps very, very difficult to read. And this is the kind of the information that's present in an IV bag. The stuff in red is considered to be label clutter. The font that I've highlighted in green is what ISMP considers to be label clutter, or what I deem to be incorrect based upon the tonicity argument that I previously raised. So, I mean, I think we can do a better job of, labeling these bags. Next slide. So, it's we already had a recommendation. We already had a statement. Dr. Kapoor said, "Can one person lead change?" Well, let's hope so. I'd like to liaise with IV fluid manufacturers to rationalize label content. Next slide. Let's eliminate clutter. Use an easily readable font, not all caps, please. Standardized nomenclature. For example, are we going to have millimoles per liter or millimoles per 100 mil? Are we going to have both? Are we going to have milliequivalents? Which one can we use consistently? Could we have color coding? Could dextrose be in green, maybe? Could sodium chloride be in blue? There's probably something that we could come up with. And we need barcoding that is easily readable, as you'll see in the next slide. Good luck with that, right? So there's been a lot of literature, and ISMP actually has some of this information on their website. It's very, very hard to read some of these, particularly when they're in the overwrap. It's very, very hard to scan them. So this is something I think we could mention to manufacturers when we liaise with them. Next slide. So what I'd like to do, I'd like to set up a forum where we invite manufacturers. We have nurses who are going to be, they're frontline, absolutely need to have nurses and physicians. I'd like to have some pharmacists. I'd like to have other people as well. If people from the general public would like to join our forum, the more the merrier. Next slide. And I think one person can lead change. I'm willing to devote as much time to this. Is kind of my pre-retirement, the hill that I'm going to end my career on. I want to make this happen, and I would encourage anybody that's present today, email me at this address. And what do you suggest? How can we? What people can we involve? I'd like to work in conjunction with ISMP to reach out to manufacturers and make some of these changes happen. That's a lot of words. I'm open to questions, or perhaps we'll move along to the next presenter.
Well, before we do that, I'll leave this on the screen a little bit longer so people can get your email, John. And it's really eye-opening how many issues there are when you present it that way, and how we've just sort of come to accept the label clutter, the way they're stored, the information that's on them that is misleading at often times. So really, thank you for this. I'm often confused by IV fluid labels. And I encourage everyone in the audience to reach out to John Manderville to share experiences, maybe provide your input, and hopefully be part of improved labeling. You really, almost every patient in every hospital is hooked up to some sort of fluid. And this is, again, all of our chances to ensure these people remain safe. So thank you, John.
Thank you.
Now, I believe most of you in the audience are clinicians, myself included. I believe that we recognize that healthcare systems and people working within it are imperfect. And in fact, you've heard a lot of these issues today. And I further believe that we all want to keep our patients safe. We want to enhance patient care throughout. So understanding and having safe conversations about errors is how we get better. It's what we're doing now. Reporting and learning is the fuel that drives this. It drives patient safety. Your facility and local organizational reporting procedures play a big role in this, and I welcome our next speakers to tell you the future of the national system for incident reporting.
Thank you, Mike. And thank you for all the presenters for all the thoughtful discussions and conversations about medication incidents. And as Mike has mentioned, the common thread that I heard from here is really looking beyond isolated incidents and towards that shared system level learning. And that's what the NSER system is about, which is the National System for Incident Reporting. Just so that I provide a little bit about myself, my name is Olivia. I'm the manager of pharmaceuticals data management at CIHI, or the Canadian Institute for Health Information. We're a pan-Canadian organization that looks at providing actionable data to help improve healthcare. And I'll be co-presenting today with Carolyn about our transition of this system. So on the next slide, you'll see a little bit more about what NSER is. So NSER itself is a pan-Canadian voluntary and anonymous system that is used by healthcare facilities to report incidents. It's not a new system. It's been around for a little bit. There's sort of two components to it. One side is the medication component, known as the MD side. This was launched back in 2010. And then there's the RT component, which is specific to radiation treatment incidents. And that's been around since 2017. You'll also see that on the right-hand side, the numbers that we've captured over the years is significant. So as of December 2025, we've had over 100,000 medication incidents reported and about 9,500 radiation treatment incidents reported. And we currently have 10 participating jurisdictions contributing to this system. So we're here today to talk to you about the new information, which is around the transition of NSER from CIHI to ISMP Canada. The two organizations have been working very closely together to transition the management and operations of NSER, including both components, the MD and RT, to ISMP Canada by March of 2026. And this transition aligns with CIHI's ongoing transformation and commitment to focusing our efforts where we can have the greatest impact in the healthcare system. And so I think I'm preaching to the choir here as to why ISMP Canada is a great fit for leading NSER moving forward. clearly comes with the specialized expertise and proven partnerships in this space, and also aligns very closely with their mission alignment and their value for innovation as well as growth. I do want to give a shout out to both CAHI and ISMP Canada teams for the ongoing fabulous collaboration we're having in terms of moving things forward. So this is a snapshot of the timeline. And so you'll see back in November, we had made a joint announcement together about how this transition is happening. Since that time, CAHI has been stopping enrollment of any new healthcare facilities, and we're parking that until the new system is up and running. In our current stage right now, we are working collaboratively on the transition of various pieces. ISMP Canada is developing the application, while CAHI is securely transferring historical data. By March of this year is when the transition will be finalized, and there will be more details from the ISMP Canada side as well as the CAHI side, where we decommission our current existing system. And then April is our go live, where ISMP Canada will assume full management, and that's when a new enrollment will begin again. So I'll hand it over to Carolyn for the next few slides.
Thank you, Olivia, and a shout out to you and the entire CAHI team for the great collaboration. We really appreciate it. ISMP Canada, with the support and collaboration of CAHI and Health Canada, is ready, willing, and able to advance the integration of Answer into our operations as an ongoing component of the Canadian Medication Incident Reporting and Prevention System. We will work with the Answer organizations and the Answer users, and we will build in the reporting and learning processes into our cycles. What are our cycles? Here briefly: learning, sharing, and acting. Learning from consumer, community pharmacy, as of April 1, hospital, long-term care, radiation treatment, and our ongoing individual practitioner and coroner incident reporting streams, all coming into ISMP Canada for analysis. And with that analysis, there are always key findings. And with those key findings, there are evidence-informed actions for improvement. There are many ways we distribute them. Just briefly want to make sure you know about our safety bulletins, our consumer newsletters, our medication safety self-assessments, things like our high alert medication list, workshops, e-learning modules, and of course today, a great example of how we share our work and collaborate and learn with you. And then finally, the acting component of our cycle, where we work together to support and sustain actions for improvement. This is an ongoing cycle. It never stops. You have learn, share, act cycles as well. On the next slide, we want to just point out for the Answer users currently that ISMP Canada is collaborating with your provincial organizations, your facility contacts, and developing new data sharing and service agreements. That's underway. Stay tuned for further technical and operational guidance to support required actions for data submission. Special thanks to Health Canada and CAHI and all our purposeful partners across Canada and around the world. We wouldn't be here and we wouldn't be doing this great work without you. On a personal note, this is my last Med Safety Exchange webinar as CEO of ISMP Canada. I wanted to extend my gratitude and appreciation to the board and staff of this extraordinary organization. The dedicated, hardworking staff are amazing, and the last 8 years with you has been a privilege and a pleasure. I will transition to part-time work as of April 1. Not sure where or how, but I will be continuing to my passion and my pursuit of improving patient safety and reducing preventable harm. I hope to see you all on that journey too. And as we wind up the answer, we wanted to make sure you know how to get a hold of CAHI, how to get a hold of us, and so our emails and websites will be helpful. Back to you, Mike.
Thanks so much, Carolyn, Olivia, and everybody. As Carol launches the feedback poll, We want to thank you, the audience, for spending time with us. This marks the end of our 9th season, so we're looking forward to our 10th season and ask you to contribute. Feel free to present, even if you don't have all the answers. There's lots that individuals can do. There's lots that organizations can do. We'd love to hear about what's happening in the areas where you work. So again, the link to this webinar will be available in the coming weeks once it gets edited. And really appreciate you spending time with us. And we hope to see you again back in spring. Hopefully it's warmer, there's less snow, but we're still highly involved in medication safety. Thank you so much, everybody.